Okay, Annalisa, thanks a lot for inviting me here. And well, I'm try to get some opposing arguments why contrast ultrasound is not the right method to detect and characterize focal liver lesions in cirrhotic patients. Well, my starting position today is nearly hopeless, as you can see. So when I was just preparing this talk, I went through this agenda, and I saw about 19 very enthusiastic talks why contrast ultrasound is very good. And then there's me. So my position here is quite hopeless. Also, the faculty is a little bit imbalanced. So I could only recognize 2 radiologists. The rest of you probably are hepatologists, internal medicine experts. Well, nevertheless, I hope that you had a nice evening, and the talk was planned a little bit earlier today, so I was hoping that you're still a little bit drunk and you're not so alert. But well, probably now you are completely awake, and my job will be even harder than I expected. So my topic today is to tell you, well, contrast ultrasound is not always the best technique. You should not be too enthusiastic about it. I would comment on some aspects of the reality. As you will see some limitations of contrast ultrasound. I checked the literature, and I might have been a little bit selective, as you will see, and there will be a lot of discussion on this. I will talk just briefly on costs. I know some arguments might sound a little bit provocative, but this is it's my topic today. And this is an interactive lecture, so please, you can interrupt me. You should participate in the cases that I will show. Just to comment on the reality, as you know, not all patients are as we would like to have them, so most of them are obese. They might have ascites in cirrhosis. I would comment on detection rates. We already have seen some studies, and I would have some other arguments on this. Lesion sizes is a topic, pseudolesions, and then I would just like to comment on imaging strategy, workflow, manpower, personal power, and well, just to start, when I was thinking about ultrasound, I would ask myself, can I see the liver at all? So just commenting on obesity, I checked the data from Euroson studies you can see down here. So these data are just they're just worrisome. As you can see, about 60% of all male adult patients are obese, about 45%. And then in this group, let's say 45 and up. So these are the patients probably that have quite a good chance to develop a cirrhosis if they do not behave like we would have them to do. So then we would have about 2/3 of patients at least being obese in ultrasound. And this would be just an example. This patient, he's 63. He was obviously too large to just fit in the MR scanner. The ultrasound was somehow inconclusive. And just to show and to start here with a quite simple example, well, this is what it might look like. You have a really obese patient. You can only evaluate these upper parts of the liver and then down here. So as you can see, this seems to be quite fatty and cirrhotic. Down here, it is quite hard to analyze the whole liver. This is the advantage, and I would argue from the position of a radiologist. I frequently use CT and MRI, so this is usually not a problem to see the whole liver. And you could even measure and see how fatty this liver is. Even after contrast medium acquisition, you have a density of 5 Hounsfield units. So this is obviously a cirrhotic and massively fatty liver. And then you have 2 other phases, arterial phase and 3 minutes post-contrast. And as you can see, there is one area here. So as the rest of the liver is quite fatty, obviously this part here, and this is not an enhancement, and this stays nearly the same. So this is obviously just an area, and this is quite often in this area, that is not that fatty as the rest of the liver. So this would be my first point. Using CT is usually a method where you can at least evaluate the complete cirrhotic liver. And another a disadvantage of these obese patients with ascites is that you might see images like this, that you're not able to, to evaluate the parenchyma of the liver in a whole overview, that you have these this ascites around. So this might diminish your ability to completely see the liver. And this is also a problem in MRI, as you can see. So if there's some fluid around, then it gets quite difficult. This would be a T2 imaging to see all parts of the liver after contrast application. Well, then at least you can see everything. But there is still also for MRI some problem. CT, if you cannot evaluate any further in this cirrhotic liver, usually works in all patients, and you can apply all these different contrast phases, and then you're able to see the whole liver. Well, these were just two examples to start why ultrasound and contrast ultrasound might not be the best technique. But the topic today is detection of and characterization of focal liver lesions in the cirrhotic liver, and we would expect HCC. This is what we want to see and evaluate. We might see ICC, intrahepatic cholangiocellular carcinoma, and then there might be other lesions, but I would not like to comment on these because this is the topic is focused on the cirrhotic liver today. And well, we heard a lot about guidelines so far, and probably you're much more experts in these guidelines than I am. As you can see, there are differences between countries. There's roughly every 5 years fundamental update, and then of course there are HCC screenings programs that I would like to comment on a little bit later. And this is what we want to see. We already have heard about this, different stages of these nodules that we might see just in the B-mode ultrasound. As you can see, these are just progressing to early HCC and progressed HCC, and we have to subdivide between small lesions and larger lesions. And I would not like to comment on this topic. This is something different. So then, preparing this talk, I carefully checked the literature, and as the main hallmark to detect HCC is still arterial hyperperfusion and venous washout, and there will be for sure some discussion about this washout, as we've already heard. Is the washout only just a little bit? Is it just complete after 2 minutes? Well, there will be some discussion a little bit later. And then I was just checking for these 2 meta-analyses for the sensitivity and specificity of different imaging modalities. And as I'm a radiologist, I started with a CT and MRI. And as you can see, I was expecting CT to be better in the sensitivity of detecting and characterization of HCC, possible HCC lesions. So this was a little bit disappointing to me. Specificity was much better. And then as you can see here, MRI overall is better, and also if you use these intracellular contrast media, you're getting better and get better sensitivities. So then I checked the data for contrast ultrasound, and well, initial studies, but I'm quite sure this is due to the limitation in former times that the technique was not that good. Sensitivities were quite low, only up to 50%. And then there was a recent meta-analysis just finding that contrast ultrasound has a sensitivity of 0.85%, including many studies to characterize HCC. And I was a little bit astonished. And this is really a limitation of all these studies. There was no restriction in size, and I think, but this is my personal view, this is a kind of, I would not say dishonesty, but a limitation, because when you want to include many of these former studies in these meta-analyses, probably there are only a few that are really focusing on small lesions. So this is why I would not take all these data that I can really trust on these. And then there was I found this meta-analysis already also in a recent article, and they focused on so-called small HCC, and they found that contrast ultrasound compared to CT is roughly the same, comparing the specificity and sensitivity. But, well, small in this meta-analysis meant lesions smaller than 3 centimeters. And to be honest, I think this is a little bit this is a little bit inhonest if you use quite large lesions, even if they are smaller than 3 centimeters. Because I think there's a huge difference between, let's say, lesions between 1 and 2 centimeters and lesions just up to 3 centimeters. And then, because this would be my argument to tell you, well, MR might be better in detecting and characterizing HCCs in cirrhotic livers. This is an interesting study that I would like highly to recommend to you. Well, there were 228 patients with a cirrhotic liver, and as you can see, they used in this study different MR sequences. And as you're probably aware of advances in MR imaging, also using these hepatocyte-specific contrast media, also diffusion imaging, of course, the contrast dynamic. They just tried to find the best combination just out of 3 of these different sequences, and they found that if you combine arterial hyperperfusion, diffusion restriction, and hypointensity in the hepatobiliary phase after 20 minutes, then you get quite high sensitivity, as you can see here in the entire population, about 96%, and even higher in these small lesions. And this is interesting here. So if you have small lesions compared to all these other studies, so my impression here is if you use MRI, you're much, much better than using contrast ultrasound to correctly characterize a lesion as an HCC. But I have to admit that specificity was quite low in this study, so you have to be a little bit aware about this. I'm not quite sure if this is really true, and this is as you and this will be maybe a huge discussion. So we heard about the pattern of the washout in contrast ultrasound. And I found this study here from 2010 from Barcelona. And to be honest, I'm not quite sure if this is still valid. Probably you will disagree with me, but I know you're experts in contrast ultrasound. So I found that this study, at least, they had 21 patients with a single lesion each, and they found that in about 50% of these lesions there was an appearance consistent with HCC washout, and this is quite well worrisome, as you can if you want to characterize a lesion in a cirrhotic liver by ultrasound. Well, this would be like flipping a coin between HCC and ICC, so this is quite worrisome, I guess. I know there are different data on this topic, and we have already heard about this, but still keep in mind that you're the experts, and I'm not really sure if you can really expect others just starting with contrast ultrasound to be able to be that experienced to maybe to diminish this problem here. There's another study confirming the same data, and I'm still convinced in this context that probably CT is not better than contrast ultrasound, but my personal view would be that MRI is better if you have a lesion to differentiate between HCC and other malignant lesions, for example, like ICC. So some further comments, and I know the lunch break is coming soon. This is the usual topic also in radiology. Satisfaction of search. You have maybe heard about this. If you see just one lesion, then you think you're done, and then you might miss another lesion. Of course, all mistakes are done in other hospitals, and not these images on the left side are just from an external ultrasound. I just found this image, so there's something marked here, probably somewhere down in segment 5 or 6, and then somehow the patient was sent just after this ultrasound to our department, and then this was quite astonishing. So obviously there is a arterial hyperperfused lesion up here, washout, and the contrast diminishment in the hepatobiliary phase. So this was just quite a large HCC, and as you can see, so probably this area is the worst for the ultrasound. If you want just to through the ribs, if you want to see even large lesions up here in segment 8, you might miss these lesions, and this becomes even worse if you have this satisfaction of search. You might just see one lesion, and then, you are not aware that you should just go on and see what else is happening. Just one short case, and this patient, this is also from an external hospital. The result was that there might be a diffuse HCC, and this was also confirmed by the contrast ultrasound. So the patient, as far as I remember, was not very compliant. However, coming back, the patient got also an MRI. As you can see, there seems to be some arterial hyperperfusion, some washout somehow. And then the patient came back some month later, and this looks really normal in the venous phase. Also, the diffusion imaging just shows no problems. And just looking back at these images, the post phase and also the fat image in Dixon imaging, as you can see, so this is just fatty infiltration in the right liver lobe. So this is just one case where contrast ultrasound and also, I have to admit it, CT was really confused. The solution is then always MRI to confirm that this is just fat. And I have another nice case here. We've already heard about this. This is just a pseudo lesion. So this seems to be, and this was as far as I remember, this was at least a discussion going on. Is this just an HCC in the B mode ultrasound? With MRI, you can be quite sure that this is just nothing, as you can see in the contrast phases. So there's no real uptake in the arterial phase. The venous phase is, you can just hardly see this lesion, and then you can be quite sure that this is just a little bit less fat than in the rest of the liver. And this is the advantage here is if you use MRI, you can be quite confident that this is not a malignant lesion, and this is what I'm missing in contrast ultrasound, to be that confident that the lesion that you see is just nothing. Just another example of an HCC. This is quite simple on the CT scan. This would be a Lyritz 5 lesion. You have the washout. You have even this pseudo capsule around a strong arterial. Sorry.
Do you think there is washout there? Because this is a matter of debate.
Yeah.
Because the capsule often is intriguing. The degree of enhancement with the enhanced unit inside the lesion and outside seems similar there.
Yes. This. I'm not quite sure if this is really a matter of this projection here, but I think this is another discussion. I guess there was some washout inside. Maybe the slide is not perfect to show this difference here. But this was in my view, as I remember, this was a clear HCC. And then I was wondering, well, these large lesions also in contrast ultrasound are usually not a problem. But what happens if you have small lesions like this in segment 3? As you can see, there's only a 5 millimeter lesion down here in segment 3. You see the washout already in the venous phase. You see the diminishment of this uptake. And then you see also a problem in the diffusion. So you can be quite sure in the MRI that this is a small HCC. And probably this will also be a topic for our discussion. Are you really able to be really confident in contrast ultrasound? So I would guess that you would see it in a B mode if you're really careful, but I doubt that you would be able to clearly say this is an HCC if you just use contrast ultrasound. This is not always a matter of size. So this is an interesting patient with a morbus Osler. I have to admit this is not a cirrhotic patient, but well, somehow there was this large lesion. So this is just an hemangioma, this large lesion here, and this seemed like an FNH, you would guess. So there's this this scar in the middle. As we have a look here at the arterial phase, this would be a subtracted phase just to show where's real enhancement. As you can see, well, the arterial enhancement is not really stronger than in the rest of the liver. But this might be also due to this morbus Osler. And then you see this washout in this later phase. So this was just a case where contrast ultrasound was not conclusive. To be honest, MRI was also not really conclusive. But then, well, the final diagnosis was that this is just a large HCC. So you have to be really careful. But this is in general, not only with contrast ultrasound, even in these very large lesions, that you do not mix them up with just other typical lesions like FNH, for example. I would like shortly to comment on the correct identification of the number of lesions, and Fabio also already commented on this. From my point of view, all these studies, they try to focus on the so-called ideal situation. You have a patient having only one lesion, and then you that you see in the B mode ultrasound, and then you need a characterization. But from my point of view, reality is usually different. So you have many patients with more than one lesion. You have different lesions. You have different tumor stages. They change over time, and then there's no chance with the ultrasound to go back and check how the lesion looked like maybe 6 months or 1 year ago. And this is the advantage clearly for MRI and CT, because you can just review all these images. Well, from my point of view, in doubt, then cross-sectional imaging is needed. And this is just a nice example here. This patient had many small HCC lesions. As you can see, the arterial hyperperfusion. You see the washout already in this quite small lesion, less than 1 centimeter. And then checking all these other images, the patient was suffering from many new in the over in this follow-up, many new of these small, tiny arterial spots, and this turned out to be more than 15 of these small HCCs. So I think this is no doubt a limitation of the contrast of the ultrasound and contrast ultrasound, that you have no chance to compete with cross-sectional imaging in the evaluation of the number of lesion and the evolution over time. Some comments on costs. So the usual situation would be that you use B mode ultrasound just for screening, and this is just as we heard from the guidelines. And then if you see a lesion, then you have to think what's next. You would need definitely a second imaging modality. And then, well, staging. So this would be, I would vote for cross-sectional imaging here, but because as soon as you see a lesion, even if you do not know this is HCC or not, you would get just the staging for free if you use CT. And then having a look at these cost studies, from my point of view, they just focus on one lesion and you want to confirm HCC with another imaging modality, but this is not the reality. So they just completely ignore all these costs for additional CT scans that you would then need if you just use contrast ultrasound. And if you carefully look at these health technology assessment studies, I just saw 250 pages how to use all these imaging modalities properly. Well, the final the final comment was, well, this is still undecided and we need more data. So it is easy to say contrast ultrasound is much less expensive than MRI or CT, but this really depends on the really focused situation, and the overall costs might not be that good for contrast ultrasound. Some last considerations on personal power and man and woman power. Well, who's offering imaging? So this is usually sometimes a battle between radiology and hepatology or internal medicine in general. Probably the advantage of radiologists is that they have these machines and they are able to perform this all these examinations, and then they are able to interpret it. So mostly all radiologists. If you would ask your colleagues in internal medicine or hepatology, most of them probably will be able to provide a good B-mode ultrasound, maybe 50%, but providing a really good contrast ultrasound, probably this number is much lower than 20%. I'm not quite sure, but this is what I would guess. So I'm not quite sure if this is really possible to offer a good quality of contrast ultrasound everywhere where it is needed. So probably we have to discuss with patient. If you really want to use contrast ultrasound, then probably patients would have to travel longer distances just to come to centers where are really experienced experts. And this is a disadvantage compared to imaging that you could basically have everywhere and also get an interpretation everywhere. Actually, I would just skip this last slide here, but this is because this is a different topic and I would suppose you're hungry, but I would like just to summarize my talk here. From my point of view, detection rates and the value of characterization for HCC, MRI would just give a better value for money, and this is even better if you use intracellular contrast media. This is also true for this topic HCC versus ICC. Just to repeat this argument, from my point of view, all these meta-analyses are a little bit unprecise. They do not focus on this interesting group of small lesions, 1 to 2 centimeters. And then always keep in mind, can you see the liver at all? And could you see the whole liver at all? And then keep in mind that there will be some additional costs for staging examinations. So if you have the impression, well, this lesion that you've seen in the B-mode ultrasound might be an HCC, then probably staging is needed. So maybe then it's the better way to use cross-sectional imaging to get this basically for free. And always keep in mind there might be multiple lesions. There might be situations where you want to plan surgery. So then I think you would agree then a contrast ultrasound is not the best way to get an overview on the whole situation. And I think it's a matter of training, but I'm quite sure that you're working on this, that we need much more doctors that are really well trained in contrast ultrasound. Otherwise, it is quite costly and would lead to many situations where the situation stays unclear, and then cross-sectional imaging is needed. Thanks a lot for your attention.